First of all, thank you for being here. Thank you to the family that have traveled to come here, notwithstanding the bad weather yesterday. Thank you to the doctors that accepted my invitation, notwithstanding all the hurdles and troubles. And I'm really happy to have you here. This is our third experience. We have grown up a lot. Every time we meet, it is an emotion, even grower emotion, and there are new families, so I'm happy to see new faces and families with children. Some of them participate for the first time to this meeting, so today is the day dedicated to the scientific session during lunchtime, but I will remind you also later at 1 o'clock we interrupt, we'll have a break, we have the time to chat, and we wait for the brothers of some of the children that this morning had an intense activities or trips and excursions, and we'll come back here around 1 o'clock, 1:15, and then we will have a group photograph, because we have never been well organized for a group photograph, but it's nice, and outside there's a lovely weather today, so we have enough time to arrange everything for lunch that will be served in this room, while in the breakfast room there will be table to serve the meal to children at 1 o'clock as soon as we finish. They will need half an hour to arrange the tables, but there's enough time. Other few technical details before passing the floor to Professor Cocchi, because we are slightly late. We'll try to speed up. After lunch break, we resume at 3 p.m. sharp. So take your time to have a nap, but please be here punctual at 3 o'clock, because in the afternoon we have very dear, precious doctor that found the time to be with us today, but they have very limited time, so we have to be punctual. So I will be very strict today, also with the speakers. So I will try to maintain the pace and to cover the schedules. Thank you for being here and enjoy this conference. Thank you, Samantha. Just few words after Samantha's word. Today, it's a very important day, because we will talk about new results in the scientific research, and we have the opportunity to meet, to stay together, to have a better integration and interactions among families, and with us, that we take care of your children. And the title of this day is From Research to Daily Life, just to underline the fact that it is not mere research, but it is focused on finding new remedies, or to better interpret the situations, the causes, the elements that lead to the birth of a child with this kind of alteration. It has been an effort, a huge effort by Samantha. This organization has been a huge effort, so we would like to thank Samantha Carletti, because he devoted her best energies to the organization of this conference, which is particularly important, not only for the social point of, from the social point of view, but also from the scientific point of view. Thank you for being here and have a nice day. Thank you, Professor Cocchi. I would like to invite Dr. Rocca. I'm sure you know him very well. While for the newcomers, Dr. Rocca wrote thesis on the Pallister-Killian. It is the first doctor with a degree dedicated to Simone Boccherini, and this year he concludes his specializations and his cycle of studies and his final dissertation for the specialist degree will be on PKS. So it's our guardian angel for today. So I pass you the floor. Thank you for being here. Good morning. I will try to be brief and trying to describe the news concerning the literature and the research at international level, to introduce all the guests that you will meet during the day that will describe all the works and research studies concerning this disease. I would like to show you this graph concerning the history of Pallister-Killian syndrome, which is has been defined the first time as mosaic syndrome in 1987, then redefined as Killian syndrome at the beginning of the 80s, and then finally named Pallister-Killian syndrome, clearly recognized as two different identities with the same chromosome traits in 1985. I would like to show you how there are, every 10 years, there are many more publications and much more literature regarding these syndromes. It is particularly important also the creation of families association. The first one, the American ones, in 2006, and the Italian one in 2011, but these are not the only ones. And as you can see, looking at the graph, you can see that the number of publications keeps on increasing quite quickly, thanks to the contribution to the data provided by families. And thanks to this data, it is possible to carry out research and to carry out new observation on the syndrome. Nowadays, on PubMed, you can find roughly 230 publications on Pallister-Killian syndrome, divided by different sectors. Roughly 30 about genetics and diagnostics, at least 100 case reports and 8 reviews, that is to say, collection of group of patients and the relevant observation and data. We can say that in literature, at least 200 patients spread all over the world are well known. I would like to focus on the last few years, and I would like to outline the most important research work carried out regarding genetics and the chromosomic explanation for Pallister-Killian syndrome. The novelties in terms of diagnostics and management and clinical and therapeutical approach, trying to focus on how every single research work can be part of a puzzle, part of a bigger mechanism, which is continuously enriched by observation and substantiated by previous observation. In 2012, the first attempt to define the minimum chromosomic region has been carried out by the Kranz group, thanks to a patient with chromosome 12p duplication and a literature review of other 25 patients. Thanks to this work, it was possible to hypothesize the presence of a small region inside the 12p chromosome containing few genes that could be the most important ones and the responsible to define the clinical features common to all the patients with Pallister-Killian syndrome. In 2014, the same research group, through additional research, especially on fibroblasts of 17 patients with this disease, proposed that few specific genes inside the region previously mentioned, with a sort of cascade effect, not only concerning the genes inside that region, can be considered as the probable responsible for few specific features such as diaphragmatic hernia, cardiac phenotype, the presence of cleft palate, and some skeletal features. The pattern of growth for which some of this child bone with the body weight bigger or with features that are developing quicker, especially in the first years of life, and other features. From the diagnostic point of view, it is possible to distinguish two different areas, the prenatal and postnatal area. I don't want to mention anything about the prenatal area because this is the presentation of Dr. Salzano, but the most recent one has been possible thanks to the collaboration with the American Society with an extended review of the literature in the attempt to better define the prenatal profile of children with PKS syndrome in order to define and suggest a few recommendations, or we can say guideline, to the diagnostic approach in the prenatal phase. From the postnatal point of view, together with the traditional techniques such as karyotype and the fish, subsequently added as another kind of research to provide a better diagnosis in these patients, we can also count or rely on the new technique, which is defined as molecular karyotype, which has the characteristic of being much more sensitive, allowing to identify the extra chromosome in the blood, also in patients where the traditional methods were no longer reliable or effective, because you know that the blood tends to lose this chromosome, limiting the diagnostic. But the advantage of this new technique is that we can provide a diagnosis and identify the isochromosome also on different tissues, not only in the blood, but also in fibroblasts that could be obtained only with very invasive methods. For example, thanks to our HEGH, it is possible to diagnose through the analysis of saliva, avoiding invasive diagnostic technique. As you can see, there are research work published on 2013, reviewed recently, and this just to underline that this method is very simple, but can be very effective and can avoid very invasive passages. An American research work of the France group that involved also Dr. Salzano involves the use of other methods like this one, which allows to amplify the DNA of these patients, also starting from very small sample, and to multiply the amount of DNA to have a quicker and better diagnosis also in cases where the isochromosome is present in very small amount. And thanks to this method, it is possible to amplify samples to identify and collect the isochromosome and to have a better diagnosis also in those cases that were not previously diagnosed because of the too small amount of material. And then there is also a new possibility, which is something between genetics and clinical practice, to collect phase 2 gene technique, which is a computerized technique, in order to try to better define facial traits. This is a new tool, and in the recent years we have seen many new tools of this kind. And thanks to this technology, the clinician can acquire images, photographs, that allow a better observation, and in order to compare these photographs with the traits that could be common for this disease. In particular, PKS and syndrome of a man have been diagnosed, and those syndromes are characterized by mosaicism and very special phenotype trait. All these photographs have been compared with photographs of children affected by other syndromes or with children with no syndromes at all. And in the second line, this one, I would like to point it out. As you can see, the PKS seems to be easily identifiable by the system thanks to this new technology. And as you can see, the system has identified more than 60 patients affected by PKS, and the result is correct. It is PKS. Using 30 photographs, in 30 photographs, there were signs, just signs, but not the clear identification of the syndrome. But as you can see, this syndrome is not confused with other mosaic syndromes. So these are very important tools that can be a great support for clinicians, but also for laboratory technicians, and they can be a great support for a better diagnosis and a clear identification. For what concerns clinical aspects, a series of reviews has been made. The first one is made by this American group, and it has involved 59 patients, and the recent one by a UK group on 22 patients, allowed to process data and to summarize all these new findings on the documents. I'm going to summarize some of these traits. 2 years ago, this sort of table summarizing the clinical profiles and the clinical features that should be considered, especially for children born with suspect of Pallister-Killian syndrome. Of course, the use of scan, fundus oculi, and assessment, ABR, all these assessments are useful and recommended to an early diagnosis of children with Pallister-Killian syndrome. And of course, some recommendations are also useful for the follow-up after birth. As you can see, together with the pediatrician, the neuropsychiatric is another very important professional profile for a clear follow-up, and there is also a list of the other professional profiles involved. And as you can see, there are also a few specific recommendations concerning the apparatus and the organ entrusted. All these indications that I summarized 2 years ago were collected according to some research work and reviews that were furtherly focused on specific aspects of children with Pallister-Killian syndrome. This research work was focused on 81 patients with PKS syndrome, American patients, and it was particularly focused on the congenital cardiopathies. And on the basis of the anomalies and most common anomalies, congenital anomalies, it gave us the opportunity to define and to recommend the echo scan every 5 years after a first assessment, which is considered the zero phase, the 0 point. And this, just to make you understand that all the recommendation, clinical recommendation, are the result of scientific observation made through scientific studies and focus on specific aspects that are, of course, carried out mainly on data provided by families. An Italian research work has been carried out after the first European workshop in Bologna in 2013. It was the study involved a cohort of patients, especially from Italian and Dutch families, and that research work gave us the opportunity to outline some important recommendation. For example, when the dental analysis should be started, also using sedation to make specific assessment. This means that we need a specific team of experts, and it provided also some indication of the odontoiatric prophylaxis. For sure, and I'm going to anticipate some of the next speeches, one of the most important aspect in the last few years and one of the main need of the families is the neurologic phenotype and all the features involved. From the neurologic anomalies point of view, there is this very recent research work focused on the analysis and the review of the abnormalities that can be identified, such as malformation, volume alteration, and alteration in the signals, cerebral signals. This research work clearly demonstrates has so far it was not possible and it was not carried out a progressive studies. Most of the time observation made over the years are referred to patients that had one cerebral scan. So we have a sort of screenshot, but we were not able to evaluate following development because we hadn't a patient with multiple scans over time. Another review research work dated 2018 documented how the presence of abnormalities, especially in the cerebral area, represent a risk factor, and they can be predictive of possible neurological sequelae, especially regarding epilepsy. This research work expanded from the genetic point of view the research on the genes responsible of epilepsy and was focused on that minimum chromosomic region that I mentioned at the beginning of my speech. And it was possible to hypothesize that some of these genes could be directly responsible for the neurologic phenotype. I know that I'm talking about very complex topics, and we know that even if there are specific genes responsible, we have to bear in mind that they are correlated with other genes. So it is quite difficult to define who is the direct responsible for some features or traits. Regarding epilepsy, I would like to mention this case study carried out by an American group that revised the features of 51 out of 59 patients and observed an important prevalence of epilepsy in PKS children. Other research work were focused on not only on epilepsy but also on the paroxystic episode known of epileptic nature, but that from the motor skill, from the movement, can be easily confused with epilepsy, especially by parents. And I would like to mention an Italian research work, a first attempt to compare 13 patients, Italian patients, with a view to some specific consideration, that is to say, a prevalence, even if we are considering 13 patients, so we know that it is a limited number of patients, but a prevalence of specific type of epilepsy were observed. I would like to thank you for your attention, and I pass the floor to my colleagues and speaker that will describe in details the result of the most recent research work and our daily reality. Thank you.
Thank you, Dr. Rocca, and I would like to thank also Professor Vignoli, who has just arrived. So I would like to introduce you to Dr. Emanuela Salzano, which is very important in our association. As you know, Dr. Salzano went our scholarship for 1 year, so she took part in the team of Professor Kranz for 1 year. Thanks to the contributions of many people who help our association. And then she continued her study with Professor Kranz for 1 more year. So she is really an important element in the team of Professor Kranz. Is everything okay? We have a slight problem with the PC.
A posto, grazie. Grazie al nostro tecnico Claudio.
Thank you to our technician Claudio, who did a wonderful job yesterday night until very late. Good morning, everyone. I would like to thank the scientific committee and Samantha, who invited me today, so I can help and give my support to this event, which is, in my opinion, much more than a workshop. It is actually an exchange of information between families and doctors, and this helps us to go ahead from the scientific point of view, but also from the life point of view. Many of you already know me. I work in the genetic sector, and I was very lucky to meet you actually in 2015, to meet a group of enthusiastic families who were really interested in research and who gave me the possibility to follow this period of research, research about PKS with Professor Kranz. He could not be present today, unfortunately, but he would like me to greet everything and to excuse him for not being here. Professor Kranz, as Alessandro was already saying, is a milestone in the history of PKS, because after 20 years from the first description of PKS, he can give a first clinical characterization of the PKS phenotype through the comparative evaluation of 56 patients. This first collection, clinical collection, was made in 2012, and up to 2014, from 2012 to 2014, the number of patients referred to in literature highly increased. We are talking about more than 100 cases actually described. And the research team of Professor Kranz wanted to identify the candidate genes, working in collaboration with Mind-Cow that you can see in the image. So they try to lay the first basis of this disorder that will be identified by Professor Zumi, the critical region of Pallister-Killian syndrome. When I had the possibility to join this fantastic group of research in 2016, there were more than 200 cases described. And this was already an important target, because this meant that there was an awareness about this disorder. And this was possible thanks to research. Give one definition of research is not possible. You will see today that there are different kinds of research. There is a basis research that is made in the lab that is apparently far from the patient, but actually is the one that brings to identify the molecular mechanisms which are essential to predict clinical manifestations and also to identify therapeutic results. Then there is another kind of research which focuses more on the patient through an assessment of the real application, the possibility to apply the research on the patient. And then there is a clinical research, which is observation. It starts from the patient and it ends on the patient. For patients with PKS, families are the starting point and the final point, because gathering and collecting all the information that families give us are the essential element that we need in order to be able to go deep into the research and be able to take care of these children. When I was in the US, I tried, together with the team, to go through a very difficult path, and that is still far from the possibility of being clinically applied. It is the possibility to identify therapeutical elements and methods. There are years in which it is more difficult to identify the symptoms. The somatical traits can be easily different from patients coming from different countries. And we made all our efforts in order to characterize the clinical phenotype in a field where it is not always possible to meet personally the patient, which is a prenatal field. Why is it important to make a prenatal study? Why prenatal diagnostic is so important? It's so important because it allows to give a genetic counseling to the family, a complete genetic counseling, and to allow the family to take all the possible choices in an aware way. Early prenatal diagnostic is essential because it allows to put the pregnant women in follow-up programs. And it is essential also because it allows to activate in uterus treatments or early at birth. The congenic diaphragmatic hernia, which is one of the diseases associated with PKS, in some circumstances can be treated in uterus. In the US, there are centers of fetal surgery which approach these kind of interventions. And in case where this is not possible, it is essential to do this at birth. And it requires a team which has to be ready to work immediately on the children. And also knowing the prenatal signs of this syndrome allows to identify this syndrome, but also to exclude this syndrome where it is not present, and so to reassure the families who want to have an answer. Anyway, there is not much clinical experience on this syndrome, and it is difficult to identify the ultrasound signs which are specific of PKS. Also in the prenatal age. In the specific case of PKS, as Alessandro was saying before, I was saying that it is difficult to carry out a postnatal diagnosis because cells, for example, blood cells tend to lose the isochromosome 12p. This is even more complex in the prenatal age, where the possibilities to take the samples are limited. We usually do this in CVS at 12 weeks of pregnancy or through the amniotic fluid. Also in this case, the risk of having a false negative result is really high. So we try to delineate a prenatal profile of PKS and to see what could be the predictive elements of outcome at birth. We put together the small pieces of the puzzle and we tried to make an algorithm, a diagnostic algorithm for prenatal diagnosis. Also for the risk of recurrence. The first step that we made was have a look at what was present in literature. on this topic, and what emerged was a very small number of data and very fragmented data. Since from 1985 to 2017, only 86 fetuses had been described affected by PKS, reported as single case reports, so the global traits were actually not taken into account, and most of those fetuses had not come to the end of pregnancy because of complex malformations which were incompatible with life. What emerged was that diaphragmatic hernia was always present in Pallister-Killian. Someone was talking about increase in amniotic fluid, the reduction of long bones length, cardiac heart diseases, and enlargement of brain ventricle. So in order to give a bigger vision of this problem and to be able to understand which ones of these elements could actually mean that PKS was present, we made a retrospective analysis of case studies at the Hospital of Philadelphia, and we made a questionnaire that we gave to families, and I would like to thank the collaboration of the group of Bologna and of the groups, the American group and the Italian group. So thank you, Samantha, once again, and thank you to all of you actually once again. And we compared the results to the data of literature. So we added to this American and Italian data the data from two patients from Dr. Kapp, who works in New Delhi. I also would like to share with you some epidemiological aspects emerged from these questionnaires. The mid-age of women, average age of the women was about 38 years. And another element was that pregnant women said they felt a reduction of the movements in fetuses, and 25% actually of our children was born before the term of gestation. And then there was women with complications, and among which 40% said they had high blood pressure or gestational diabetes. Actually, they were not included in the study because gestational diabetes goes along with high weight. So we did not want to add confusing elements. And then 20% was talking about vaginal bleeding in the first trimester. As about prenatal studies, what comes out, I do not know if you can see this. You can see in the graph in blue the data emerged from our study. In gray you can see the literature, and in orange you can see the average between the two. An increase in the amniotic fluid is the most visible thing here, and then the reduction of the growth, in particular to long bones and femur in particular. And the third place you see from our case, from our graph, that literature is different from our experience. This difference, this gap, is partly due to the fact that not all the patients have the same characteristics, but also to the fact that we are focusing on perinatal period, while literature focuses, as I was saying before, on fetuses with complex malformative pathology. And then the increase of the weight of estimated weight in the pregnancy period, and the dimensions of the brain. While it is more difficult to identify brain malformations.
The same is true for primary anomalies, because renal kidney dilation is commonly reported, and also gastrointestinal problems, and when present they have an onset with an enlargement of intestinal spaces. From the analysis of the smaller patients observed, it is undoubtedly useful, the use of 3D scan capable of identify some facial traits to support the suspect of PKS diagnosis, and that in particular we're talking about the distance between the eyes, very large forehead, and in some cases we have to consider also the possible defect on the palate. About the biometric profile, that is to show the fetal growth, very few information were available, but we tried to combine literature and data provided by patients, and we were able to identify the few parameters, especially concerning the circumference of a crane, abdomen, femur, and in red you can see the curve of growth, while in black we can see the trend of normal growth. And as you can see, since the gestational period, there is a tendency to an increase of the cranial dimension, which is quite different from the normal standard, and there is a delay and a slower growth of femur, especially in the last gestation quarter. Regarding the tests commonly carried out during pregnancy, screening of first and second quarter, and those so-called invasives such as amniocentesis and biliocentesis, but in the main test no significant variation have been observed, especially in the first quarter, and it was observed that in 3 patients out of 19 and in 14 out of 16 in the literature, remember that the literature includes also the most severe cases, is the increase in nuchal translucency. And from the diagnostic methods and from the point of view of the study of fetus, it has been observed that amniocentesis is much more useful than biliocentesis in identifying the isochromosome till 95%, while biliocentesis tends to lose the anomaly and is not so effective unless specific indication from the lab, if there is a diagnostic suspect. Amniocentesis is definitely the best method. In addition, the increase of nuchal translucency is a negative predictive factor, and all the patients described in our case study and reported in the literature presented a congenital heart anomaly, diaphragmatic hernia congenital, with a worse prognosis, and the increase of amniotic liquid is an indicator, as well as a weight at birth higher than standard. But most of all, it can be associated to a risk which is 5 times higher, and 25% of the children considered were born before the term. So all these elements must be warning messages, and together should induce us to think about PKS. Actually, in the first quarter, the only important element is a nuchal translucent higher than 3 millimeters. In the second quarter, the most important elements is the macrostomy of fetus and an excessive growth of femur, can be suggestive of PKS, and in presence of a nuchal translucence history, we have to exclude other pathologies and other malformation, but in absence of translucent history, those elements must impose a further research for minor anomalies to support the diagnostics aspect. And even if carried out, even if a villocentesis should be carried out, in any case it is advisable to carry out further investigation, especially amniocentesis, avoiding long-term cultures which can give false negative results, or focusing on the analysis of fresh DNA. To complicate the situation, there are other elements, some of them similar to PKS features because focus on the same critical region, the trisomy 12p, due to the duplication of that region and clinically manifested in a very similar way, probably associated to a minor incidence of diaphragmatic hernia, and another condition, the one you can see in the last column, which is due to the mutation of a gene which is exactly in the critical PKS area with very similar trait. These two conditions are very difficult to distinguish, but there are two additional features that should be distinguished, and two additional features with Prince syndrome with a completely different growth pattern from PKS. If you know the two syndromes, you can easily understand, because in the first case children tend to have a very small growth in uterus, and the second syndrome is much more similar to the PKS syndrome, the Becker-With syndrome, but share with the PKS defect in the abdominal wall or cleft palate, but not the reduction of the femur growth and not anomalies on the chronic structure. In addition, we have tried to complete our research work trying to answer a very important family, which is the risk to have another pregnancy and to run the same risks. To be fully precise, the answer depends on the cytogenetic anomaly. Because as I said before, there are some very similar pattern due to the duplication of the chromosome arm. In the majority of the cases, when the mechanism is associated to the isochromosome P, which is a rare event and random event, so not hereditary, this involves a risk of recurrence, which we defined equal to the same risk present in the general population, and this because theoretically there are structural unbalanced anomalies not manifested in parents that can predispose this kind of imbalance. How can we exclude this situation? Just studying the karyotype with a high resolution diagnostic technique. But there is still 1% of risk, because also in this case, even if the karyotype is negative, remember that this examination is carried out on blood. And we cannot exclude that the same anomaly can be present in the egg or in the sperm. The situation is completely different if the phenotype is associated to the duplication of the short arm of chromosome 12, because in that case the question is it an ex novo anomaly, so a brand new event, a random event which happened at the conception, or there is a condition which can predispose for this result. Also in this case, a high resolution karyotype analysis is required, and of course we can distinguish in different classes of risk. If there are balanced conditions, or if there are no losses of genomic material, the risk vary between 3 to 10%. Otherwise, in other cases, like the one reported by Dr. Zumi, there is the risk of an hereditary disease focus on the same region, and the risk in this case increases up to 50%. I would like to conclude telling you that so far we have tried to outline the features to provide a very early diagnosis, and now we are focusing on outlining the pathology. We have to understand better the morbidity to be able to prevent them, and the comorbidities, that is to say, all the aspect that tends to become chronic, and we have to try to control them in order to improve the quality of life and prolong life. The last input comes from Professor Kranz, with whom I spoke yesterday, and it is referred to a study carried out in Philadelphia. He started collecting some anthropometric data, that is to say height, weight and cranial circumference, in order to define the growing curves. And as you can see, the genetic makeup of PKS children is slightly different from general population, and we isolated the population of 79 patients, each one with a number of assessment between 5 and 6, and we realized, while comparing this data, is that most of the assessment are carried out in the age range 0-36 months. So we should be able to add elements coming from children at a later age. So if among you there are parents of children, maybe older, it would be possible to keep on collecting information and to complete this growth curve and to distinguish it between male and female. I would like to conclude my speech, and I would like to thank you for the attention and for the patience. Thank you.
Grazie. Allora, ringraziamo la dottoressa Salzano. In realtà...
Thank you, Dr. Salzano. Actually, I would like to thank her for this wonderful presentation, and we have to speed up a little bit, but I would like in any case to give you the opportunity to ask a few questions, because usually we consider 20 minutes speech and 10 minutes discussion, because it is so important to have this group of experts with us. Actually, we don't have time, but I would like to introduce all our experts. I'm sure you know Professor Cordelli, Professor Viri. Thank you for being here with us. He left very early this morning. Professor Cocchi, of course, you know him. Professor Vignoli, she works together with our dear Professor Emilia Ricci. Dr. Salzano does not belong to the table of experts, but if you have questions for Dr. Salzano, please ask. Yes, we skipped the part devoted to the question, and also for Dr. Rocca. I would like to know if you suggest high definition genetic analysis also for our healthy sons. Yes, from the procedural point of view, the correct method is to carry out the analysis on mother and father, because if we can exclude that mother and father are carrier of any kind of disease, we presume that children will be healthy and won't run any risk. I would like to report you the experience in the Sicily region, and normally you have to make a request to your doctor. You have to require for a genetic analysis. Then we open a file and we ask the opportunity to make the exam, because we need a high resolution karyotype and we know what to require. Any other question? Technical information. I've lost my mobile phone, so if you see it, but I removed the ringtone, so if you see it, please tell me. Oh yeah, I found it. Thank you. It was behind Gagliardino. Thank you so much.
Minuti che lo cerca dappertutto, mancava solo il frigo.
Okay. I would like to thank you, Dr. Salzano, for being here with us. Just few minutes to upload Dr. Pippucci presentation, and then we can go on. But there is an introduction by Professor Cordelli. Now we are focusing on a new section. We have talked about research at international level. And now we come back to Italy to see what's happening now. Dr. Salzano is our trade union between the international and national research. And spontaneously, we have created a sort of center of interest on PKS in Bologna. But this was a totally spontaneous event, maybe thanks to the presence of Professor Cocchi and Professor Cordelli, that gave birth to this team, that created this team, which involves all our wonderful doctors. And it is a very important research group. So we are very proud of it, because it is the first one in Italy. It is the first one at national level, but we also include children from Austria, from England, from the Bahrain. There is a Bahrain family which was present at the conference in Cervia, and they are followed by Professor Cordelli. So I would like to pass the floor to Professor Cordelli for his introduction. Thank you. As usual, I'm really excited and I'm really happy to be here, and I will try to be brief but clear. But I would like to focus on few elements. The first one, and I'm sure I'm talking on behalf of each one of you, I would like to thank Professor Cocchi for his fundamental support. Without him, probably we wouldn't be here today. With his competence, with his passion, he is and he will always be our guide. And in short, he will have more time to devote to all of us. And I would like to tell you that, because we do expect this. The second important thing is that the scientific committee is acquiring new elements. So we have new colleagues with that, Professor Vignoli and Professor Ghieri. And the Pallister-Killian family is an inclusive family, and we are growing up. So you are in now, and we do expect from you a great contribution. You are in the web net. I would like to introduce the next speech. Where are we going, and which is our destination, which is our objective with research? Of course, we want to become bigger and to welcome new elements and new data. We are growing up the beginning was somehow quite spontaneous. People that started gathering together, sharing information. And you family were very an essential element. And now we are start organizing the research in a better way, in a global way. And it is not only a clinical research, but also a translational research, and not only limited to a specific place. Of course, we need some reference point also for you from the clinical point of view, and also for the research group to communicate. But it is also essential to collaborate with the United States group, which is already deeply rooted in our reality. And we are going to improve the synergy, because only together we can attain great results. So we are going towards that aim. It is a group made of very young professionals, and this is an advantage, and it brings a lot of enthusiasm. We have expert guys, and we are creating a great team that will give a great contribution in the future. Dr. Pipucci will represent an element which was missing up to now, the one focus on the basic research, and I'm sure that is going to give us very interesting data, combining practical and research elements, especially from the neurological phenotype. We have tried to broaden research with good result, I would say, especially in the field of epilepsy. And opening also to other sectors, very important for the daily life of your children and of your families. Sleep disorders, behavioral disorders, in order to have a basic research looking at the future and looking for potential therapeutic strategies, and the more clinical research focused on the present, the state of the art, to give always better answers, better responses, both for sleep disorders and behavioral disorders. All this will support and strengthen the competencies of an interdisciplinary groups and of a center which is becoming, as Samantha said, a reference point for all these different areas to follow children and patients with PKS in the best possible way. So I would like to pass the floor to Tommaso. Thank you, Professor. I would like to ask Professor Cordelli to introduce Professor Viri, who made very important work together with Professor Giordano, and who is present in the medical literature of PKS in Italy. And is one of the first one, actually. Of course, and with great pleasure, Professor Viri is a very reliable and expert professional. It is an element of richness, and I'm sure he will give a great contribution to this group, and I'm sure he will be happy to do that, especially in the field of epilepsy, and of course to broaden the clinical opportunities, because it would be really important to create a sort of map of expert, a group of experts. Probably this is easier in the north and slightly more difficult in the south, but it is important to support families. So I would like to invite Professor Viri and Professor Vignoli and Professor Cocchi and Cordelli to intervene, especially during the discussions, and to maintain a very lively discussion. Thank you, Dr. Pipucci. Thank you for this opportunity. Thank you, Duccio, for your invitation. It's a real pleasure to be here today and to see that there is already a close collaboration between you and the expert, and all these research works are important. I'm an exception because I am a newcomer and a neophyte of this syndrome. I'm not an expert, not yet, because I never had the opportunity to study chromosomic diseases. And I arrived to this place through a very peculiar path, but a very interesting one. I'm a biologician at the Orsola-Malpighi Hospital of Bologna, and I mainly carry out research on genetic diseases, trying to focusing on the use of new technologies, especially for sequencing. And as you know, they are not very much used. They are not state-of-the-art diagnostic tools for this disease, but also for many other syndromes. Alessandro has given you a very clear description of the syndrome, so I'm not going to describe it in details, especially for what concerns its genetic nature, but I would like to summarize some of the main techniques to identify this anomaly, which is the cause of Pallister-Killian syndromes, which is the presence of 12p isochromosome in the genetic makeup of patients. As you can see, the karyotype deficient RHGH is the molecular diagnostic technology. At the moment, it is considered the best one for this kind of disease, but also for other chromosomic anomalies or anomalies which are expressed through the alteration of the number of chromosomes in the DNA. The RHGH, as I'm sure you know, is a technique which uses comparative genomic hybridization, because it uses the possibility to identify a control DNA with a normally arrayed DNA with the DNA with the shortages or extra presence of certain elements, chromosome or genomic region. And this kind of assessment is made through the use of two kinds of DNAs that are compared and used on very special classes that can be equipped with probes, and these probes analyzes the genome at high resolution. It is actually a very quick and effective technology, and in few days we can have the results. Of course, there are many pros but also few cons, because it is not able to identify anomalies where there are no loss of the material or when there is extra material, but it can be interesting to point out another potential limit, which is the low sensitivity for low fraction mosaics. Mosaics with high fraction can be easily identified, but mosaic with the low fraction are not clearly identified due to the nature of this technology, and it is much more difficult to correctly interpret that data. RHEGH is mainly used to diagnose Pallister-Killian syndrome, and usually in our laboratory we use this technique. Dr. Maggini is the person in charge of this kind of technique, but as you can see, it includes the analysis of roughly 300 cases every year with some main indications that are disorder of autistic spectrum disorders or malformation without a clear clinical indications, and the diagnostic effectiveness is around 10%, clearly lower than 20%. I have a passion for the introduction of technologies, particularly useful to identify mutation of different diseases, so nothing to do with Pallister-Killian, maybe focus on the mutation of a single gene and focus on a very specific mutations, and observing that specific gene we can see if it can be the base for additional mutation. As you can see, the indication used are very simple. FGS, TGS and CGS are essentially three kinds of technologies. The standard technologies for many years has been very accurate with a very low production of sequencing compared with the very long frequencies. The problem is that this technology, it was possible to have a very limited work per unit of time. So we have tried to focus on next generation sequencing technologies that can produce shorter sequences but a great number of sequences in a very short time. So in few days we are able to analyze the genetic makeup of an individual. And you know that for the genome project, this kind of analysis required years. Over the last years, the third generation technologies have appeared, and this is our first experience on this particular technology. These technologies have a sequence of comparable sequences. We are talking about longer sequences, 100 sequences, compared to thousands of sequences. I'm not going into details about the technology, but I would like to tell you that having longer sequences allows a greater resolution and a greater ability to distinguish if the alteration identified in a portion of the genome are more or less interesting and more or less compatible, and this with a higher accuracy, because we can distinguish what could be impossible to distinguish in shorter sequences. And there is also another important element. We can now see a new opportunity, that is to say, using this portable technology. This is a PC and this is a sequencing equipment. I don't know if you have a rough idea of how big a sequencing device can be. It is quite big usually, and this technology in particular, which is called nanopulse sequences, has very small dimensions, and all these devices are commonly used to carry out a very quick analysis, a very handy work. You can imagine that in the future it could be possible to use this technology at home. And the results collected are very recent. This is an article published in April 2019, focusing on sequences of human genomes using this technology. And this is particularly interesting. Let's have a look to how the system works. It's quite innovative. It is a very innovative idea and a fascinating one, because this small device are made of an isolating membrane where proteins are filled in. These are porous proteins that can detect the passage of current from the upper position to the lower position. And when DNA penetrate this blend, a strand of DNA enters the pores and block the currents. And we can create a sequence through this passage. We can sequence the DNA. It is a very immediate technique. It is made in real time, and we do not have to wait for a sequencing process that should go on for a while, and that should be completed before observing the result. In this case, we can stop the experiment, and after half an hour or after 1 hour, we can see the result, because data are real-time acquired. This means that we can create a sort of chain starting from sequences to data processing thanks to the computer, which is an immediate process. And then this kind of technique is very interesting for Mendelian disorders, but also for the number of copies. And I would like to give you a few more information about this point. So we had an idea, and in cooperation with a colleague and friend from the University of Florence that I'm going to introduce to you, we decided to analyze this technology considering different chromosomic diseases, but due to smaller or bigger alteration of the genetic makeup, and Pallister-Killian is among them, because it involves the short arm of the chromosome, while other syndromes are maybe syndromes due to alteration of some megabases. So it was interesting to understand how simple and how quick could have been to identify this kind of alteration with this new technology. So this was our objective. And so we started working together, and we wrote this abstract. We sent it to the next conference of human genetics, which will take place in November in Rome. And it is a sort of summary of our results. And I would also use this abstract to thank Professor Cocchi, Professor Cordelli, Dr. Rocca, all present here with us today, and other colleagues and collaborators from the unit where I work at, in particular Pamela, which is focused on this kind of section, and Alberto Maggi, who is an engineer and researcher at the University of Florence, who collaborates also with Alessandra Mingrino, another member of the team. So we, in this study, we have collected the results in this table, a colored table as you can see, but also very simple. we can clearly define how long does it take to identify alterations involved in these different syndromes. The syndromes are due to different kind of chromosome alteration, from the biggest to the smaller. We are talking of mosaic dilation lower than megabase, but on the top line you can see alteration identified in a patient with Pallister-Killian syndrome of 34 megabases regarding chromosome 12p. Thanks to this technology, in half an hour time, from when the DNA is inserted into the device, from when the sample is inserted into the device, and from the beginning of the experimental procedure, we can identify an alteration with a mosaicism at 20%. Then there is a sort of detection limit which mirrors the size of the region interested. It is evident that for smaller region we need a higher sensitivity and we have to analyze and sequencing and sectioning more. But for a bigger region we have several sequencing reading per unit of chromosomic length, and in a short time we can have a result. And this, of course, has lots of consequences, because reducing the time and giving a quicker response and a quicker identification of the anomalies is definitely important. Also to find the molecular feature of the disease. Another important aspect, you should look at the more cryptic graphic on the top of the slide. You can see that there are many false positives, and so we need to focus on accuracy in this case. We have observed that both regarding the numbers and the size, our error, our esteem of error is quite low, and regarding very small alterations, we are talking about a group of events not bigger than 3 megabase. So for bigger anomalies we can have an even greater accuracy and a higher sensitivity in short time, first of all, but also very accurate for what concerns the analysis of mosaicism, and also with very low frequency mosaicism. I would like to show you 4 examples. We have sequenced 4 samples so far. This is a 12 chromosome. As you can see, there is an alteration with a number of allelic fraction of 20% of the entire chromosome. And as you can see, there are other cases where you can observe, this of course depends on the sample and on the age. You can clearly understand that there is an alteration regarding the chromosome, also in those cases where the RGGH has difficulties in detecting the alteration. Maybe you can see something, but the software does not recognize that kind of alteration, while with this technique also a very mild alteration can be detected. This is a similar case, and this is the final case that I would like to use to introduce another important aspect. and I will conclude with this final observation. It is an observation we consider particularly interesting because you can see alteration due to shortage or excessive copies regarding not only 12p chromosome but also the rest of the chromosome. So we are not focusing only on that chromosome but also on other chromosomes, and maybe there is a sort of genomic instability also concerning other regions, which is accompanied by the alteration of chromosome 12p. We have just 4 samples at the moment, and it is too early to say something more accurate than this. But according to the level of mosaicism for the 12p, we can also observe a greater or lower involvement of alterations in other parts of the genome. And this leads to 2 important questions. Is it possible to identify an implication of genome instability in these cells? And the second question, which is the subsequent question, is if some of these alterations can be fixed into cells that are not blood cells, the one commonly analyzed, but could be concentrated in other tissues, and that can be useful to identify the pathogenesis, and that can be distinguished and differentiated in the different patients and carriers of these anomalies. So in the future, we would like to keep on analyzing this information by enhancing the diagnostic potential and considering all the future opportunities that this kind of technology could give us. So I'm a neophyte, as you can see, but I hope to have given you and to have convinced you and to have been intrigued in the presentation of this aspect. Thank you. Thank you, Dr. Pippucci. It was perfect, fantastic, perfect on time. So we have 10 minutes for discussion. So I would like you to take the opportunity to ask questions to our professors. First of all, I try for us, for the technician, it has been a really fascinating presentation. I don't know if for parents it was easy to follow this presentation, which was quite technical. I'm trying to translate it into simple words to summarize and to point out the main implication of this kind of research. This technology could correct me if I'm wrong, please, could sensibly reduce diagnostic times, and most of all, and this is the most important implication, we could avoid skin biopsy. Yes, correct. It is correct. These are the 2 main implications in the short term, because if all these observations are confirmed, we can say that we have both a technology that could allow to sensibly reduce diagnostic times, because the HEGH takes days to be carried out and completed, while we are talking about 1 day or hours. And the second point, yes, this increased sensitivity for mosaics allow us to see something that we cannot observe in the blood at the moment. So it could in the future it could be possible to avoid skin biopsy for the diagnosis. And the second thing, which is even more fascinating because of the long-term implications, if I understood correctly, is that there are few possibility to identify the mechanism of the disease, which could be, of course, very useful. We have to be cautious, I know. Yes. In this particular situation, and me as a person, I'm always usually very cautious because we are walking on eggs, because we are walking on something very new and very innovative. But we can clearly see the results. So what we see is very clear. The result of the 4 samples analyzed are very clear. We clearly see alteration, reminding the alteration that could be observed in the same experiment, same test carried out on a tumoral sample. Of course, we are talking about 2 different things. I'm talking about genomic traits. We can see an unbalanced profile that could remind a chromosomic instability. But of course, I want to be cautious because there is a long path ahead of us. We are still using state-of-the-art analysis and techniques to be able to analyze samples. But it is true that we have carried out around 12 experiments and only 3 samples with Pallister-Killian syndrome with a level of mosaicism between 15 and 20% have this kind of profile. So we are quite optimistic and very interested in this kind of research. Difficult to say if it will be easier or more difficult to correlate all this to the features, but definitely we can say something more about what's happening in the cells having this defect. Shall we say that this technique could be an answer for the families asking for brothers or sister or for the same parents if there is a situation that with the ETGH cannot be identified while it could be identified with this technique? Yes, definitely correct. Because consider that these are experiments in which this is a pilot experiment, so the experiment was carried out just to test the technique and to observe the alteration, but of course we can increase the accuracy, the sensitivity of the device, the coverage. There is a great margin of improvements. And of course, it is difficult to predict the advantages of this technique, but I'm quite optimistic about that. One more question. Have you analyzed only blood or also other tissues? At the moment, only blood. Could it be sensible to use saliva, for example? Yes, but it could be useful to have a buccal swab or a skin biopsy to analyze different tissues, especially tissues with the lower proliferation, because we could see if there are other anomalies of this kind. Any other questions? Please. Which are the tissues with low proliferation? I would like to know which are the tissues with low proliferation you have just mentioned. Of course, the reason why skin biopsy is the preferred method is because blood tends to lose the anomalies, and so the problem is that if we lose the abnormally, it's because we have it in a smaller number of cells, because this kind of tissue tends to lose this proliferation, and this implies that when we are ready to give a diagnosis, we cannot see it because it has disappeared or it is too low to be identified. While other kind of tissues on the skin, for example, the tissue analyzed as a slower renewal and tends to lose less the anomaly. It has less opportunities to lose the anomaly, and so it can be easily observed. So if we have a higher resolution technique, we could also use blood, even if it is lower, and avoid biopsy. 2 more questions. I don't know if I have correctly understood, but is it possible to carry out this kind of examination on the fetus, so in the prenatal stadium? We can say that because, of course, now we have the postpartum diagnosis, but could it be possible to have a prenatal diagnosis with blood test or any other kind of analysis, for example? The problem of prenatal diagnosis is, of course, we are talking about pilot studies, so we are talking about future, and this must be very clear. Prenatal diagnosis follows certain ethical rules as well, and so we have to give the right importance to research. Of course, when we have powerful tools, the risk to find other alteration that we are not able to identify is very high, and so we can have worse result rather than better results. So we have to be very cautious, and if we look at the future, probably it will be possible to do it during the villocentesis or amniocentesis, because we can analyze the amniotic liquid, while for villocentesis, which is done earlier than the amniocentesis, also with a view to possible interruption of the pregnancy, it is a bit more complicated because we have to take the embryon, and not always the genetic makeup is complete, and in that case the quantitative studies could be confusing and more difficult. So we could consider to analyze the amniotic liquid. Correct. Because, of course, this is still a question mark also for us. We compared to, or with respect to other chromosomal abnormalities, we have a mosaic anomalies, and this characteristic, together with a series of additional difficulties that can be related to the use of a technology capable of identifying the circulating DNA, same technique used for the 21 trisomy, so non-invasive techniques. Difficult to answer this question. It's a bit premature, and I'm not ready, not yet, to answer this question. The detection limit of this anomaly is not known at the moment, because we don't know which is the state-of-the-art technique and the state-of-the-art research. But in any case, it is something very borderline also for our constitutional anomalies. One last question. Thank you, Dr. Pipucci. Fascinating presentation. A curiosity, the short arm of 12 chromosome expressed in different copies is different from the short arm of, or is it exactly the same? Is it different or is it exactly the same? So the anomalies generated is a macroscopic anomaly which can be identified, also observed in the karyotype, and the presence in the genetic makeup of isochromosome, that is to say a double copy of chromosome P, which is disconnected from the other two chromosomes. And this chromosome, the short arm of this chromosome, is a chromosome which can be considered normal from the point of view of its content of genes, unless small breaks or small alteration that can be observed in the process of fusion of the two chromosome 12p that create the isochromosome. Now, it is, if I have understood your question correctly, what we think about this defect is that it is a genic dosage defect. There is too much genic product in that 12p gene, and this creates an imbalance, general imbalance of all the genes. And this is the main reason of the syndrome. So nothing is missing, actually. There are no microscopic losses inside the 12p chromosome. What could be interesting to analyze if we identified other imbalances related to the isochrome 12p is the opportunity and the possibility of phenotype variation. And it is something difficult to explain. We don't know why certain individuals have a clinical history or a clinical trait different from others. So these elements should be attributed to factors that are not the main factor we are observing. One more question, because we have geneticists here with us, and compared to a diagnostic algorithms, is there something we have to differentiate? That is to say, the newborn child can be suggested to have a more accurate exam on the blood, while toddler should be treated and studied in a different way. I think that also from this very interesting speculation and observation, the element of a better characterization in terms of prenatal datum, we know that there are some alterations suggestive of potential diagnosis of the disease in the prenatal period, analyzing the phenotype and the morphological features, developmental behavior and signs that for me as clinician and infant neuropsychiatrics should trigger something. The risk is that I can also have an hypothesis, but if I choose the wrong examination, probably I won't have the answer I need. And this could be useful not only for clinicians but also for families, why we have used terms like CGHRA or high definition standards. Maybe it would be useful for families to have few more indication about these techniques, because if I have a suspect but I choose the wrong technique, then I have another 100 possibilities. I think about a child born with a defect, and then I discover that it is PKS, but at birth it is not immediate, and to have an impression, a clear impression, and to clearly recognize the size. Maybe it is a child with diaphragmatic hernia and hypotonia, and when I see a child with these features, I start considering, okay, an MRI to see the hypotonia and other tests to see other aspects. In this kind of stage, genetics analysis is extremely attractive, and of course I'm very curious about this field, but probably I'm still using tools that I don't know very well, and there are many areas in which knowledge is not so clear and evident. So in my opinion, clarification from the clinical point of view to distinguish between one technique and the other and another one could be useful. Let's say that in the prenatal period, the traits are not clearly defined, and it is an inferior process, but for an expert eye there are some facial traits that can be immediately recognized: high forehead and rounded forehead, distance between eyes, small nose, special shape of the lips. It is also called Pallister lip. There is a sort of cutaneous features on the upper lips, and hypotonia, as you have already mentioned, with all its consequences. It is difficult in the prenatal era to identify hyperpigmentation or hyperpigmented area that should be always suggestive of mosaicism, possible mosaicism. This must be a warning message and inducing the doctor to consider a genetic alteration, and this can give the first indication for the sample to be chosen. And then of course we have to combine all this with the phenotype, with the prenatal history, because at that time the collection of amniotic liquid is very important, and the diagnosis of macrosomy in the prenatal area or other features can be a great help to orientate. Or sometimes we can identify a very similar syndrome, and sometimes there are syndromes with very similar sign, like the one of Beckwith-Wiedert, which has similar trait at birth, and children with Beckwith and children with Pallister-Killian have more or less the same gestational development, except from the diaphragmatic hernia. They have no cutaneous pigmentation. They have macrosomia, more difficult to be identified, and in that case we need a very sharp clinical eye. Then there are the flat angioma and aclabella, series of elements. It's like a puzzle that we have to compose, and that trigger the diagnostic suspect. To identify Pallister-Killian in the prenatal area and until 12 months of life, blood can be used. So using cells after the hematic life, it is more difficult to identify mosaicism, and in that case the golden standard is skin biopsy, even if we know that it is a quite invasive technique. We have started trying to identify mosaicism on a buccal swamp, and then doing the HGH on this buccal sample, and we have a good response up tonight. And in case of doubt, we also consider a compared evaluation using blood sample and buccal sample, and we try to compare them. And I go back to the question previously asked, because mucosal cells have the same embryogenetic origins of the fibroblastic cutaneous, and they are quite similar to nerve cells that tends to replicate in a limited way, but of course that are difficult to analyze. I hope to have given you a clear answer. Talking about saliva, Sarah, she's 11 now, and this phenomenon has been is decreased, but she has a very special saliva compared to the other children and to my saliva as well. It is much more viscous, much more solid, sorry for the term, which is not technical, but just to make you understand, much more thick and very different from the other ones. So in my opinion, focusing the analysis on the saliva, it could be useful because it is a trait, it is a sign that we as parents immediately observe. This is a very important food for thought, not only because of the change of consistency, because it is influenced by the hypotonia, but her gastritis worsened, and of course the hypotonia of musculobuccal muscles can have an impact on that, and also the consistency of saliva can change, but it is a definitely interesting observation. For sure, it has been already identified, not analyzed, not yet, but it is clear that there is an important role played by the autonomic nervous system, the nervous system that we cannot voluntarily control, but which has an impact on secretion, on saliva, and also on respiratory patterns. There are some research work that observe that PKS patients can have more or less peculiar abnormalities, even if the mechanisms behind them have not been clearly identified. At the moment, they are still observational information. One question regarding diagnostic. We are talking about and with people knowing the PKS, but all this information, because we know that the clearly recognized cases are very few globally, but not because not existing, but just because not identified. So all this information, do they remain just among the circle of the expert, or they are widespread and diffuse to improve diagnostics? The attempt is to disseminate as much as possible, and the first means of dissemination are scientific publication. Also the data I have suggested at prenatal level are now available, and so you have free access to data. And of course, dissemination should be enhanced also during conferences like this one among the different societies. SIP, CGS. SIP is the Italian Society of Pediatricians, and CIG is the Italian Society of Genetics. So we are working in a field which is between pediatric field and genetic field, and so yes, it is something that we should do, presenting research work and exchanging information continuously to create a synergy. And also this information could be also for the neonatologist. It is condition that could be diagnosed for what concerns a phenotype, but you know that they are very blurred and mild forms. So if the first step is carried out by the neonatologist, and if he's not able to identify this trait, there can be a delayed or no diagnosis at all. I would like to say that thanks to the PKS Association, all the information observed, all the information carried out are published and disseminated and spread at every conference, every meeting. And this is essential because we create a sort of cascade effect which broaden and strengthen research. And Italy, in this field, is a country where this kind of culture on rare diseases and on the research on rare diseases is definitely one of the most important elements. Thanks to the association and through their collaboration with the doctors and this synergy, so we should keep on carrying out this research at European level and also at extra-European level. I would like just to add that there is an aspect that put this topic into a wider framework characterized by the insurgence and onset of diseases due to mosaicisms, which is common for many genetic diseases. Early diagnosis and sensitivity and accuracy of the method of research and all the different clinical shades are aspects that can be correlated to the fact that the mechanism of this disease has this kind of defect. And I would like to underline the scientific and assistant interests that are going hand in hand in this kind of research.
Thank you, Dr. Pippucci. Thank you for this very important exchange of information at a very high level. Thank you. I would like to invite Dr. Cagnazzo. What Dr. Salzano would like to add something to complete my answer. I don't know if you know that there is a manual, a genetic manual, the Cassidy, which is internationally recognized. The last edition is was published in 2012 and of course does not contain the PKS chapter, but together with Professor Kranz and the Genetic Council collaborating with him, we have written a new chapter that should be published in short, and this is a very important first step.
Hello everybody, I will try to be brief. I would like to start talking about the study that we're carrying out in Bologna about the neurologic phenotype in PKS. And I will tell you something about my thesis, a part of my thesis about the neurological phenotype. And I am talking today about the retrospective study, which is a part of my work. Then Professor Ricci will talk about a different aspect because we have had new patients, and so she will focus on this aspect. In particular, our study concerns epilepsy. In literature, in the PKS literature, what do we know about neurological phenotype? We talk about hypotonia, of motor delay, of intellectual disability with variable severity, behavioral disorders and malformation of the nervous central system, and epilepsy. We do not know much about epilepsy. literature is really limited in this field, also because of the way of collecting data. What do we know? We know that the incidence is between 40 and 70%, so also this data is variable. And literature is not rich. There are 27 patients in America who have myoclonic seizures. Then there is a study of 13 Italian patients with epileptic spasms, and then there are different case reports. But there are several limits because the data are collected through questionnaires which are filled in by parents, and not always EEG are collected, and not always this data are examined by the same person. Very briefly, what do we have about literature? We had a sample of 51 patients, of which 27 with epilepsy. The onset happens very early usually. Myoclonic crisis seizures are the most frequent, and parents said that the most efficient medicine appeared to be levetiracetam. The data had been collected by parents through a questionnaire, and EEG were not referred, so they had not been examined by the same person. In Italy, there was a study on 13 patients with epileptic spasms. In this study, there was a clinical assessment, EEG assessment, and a neuroimaging. What comes out is starting to come out is this relation with brain malformation. Does it exist or not? Is epilepsy caused by structural anomalies or not? This study shows that 4 patients out of 13 do not have structural anomalies but do have epilepsy. And there is a case of photoreactive myoclonic seizures. Then there are other minor studies. You see that in one study from Britain there are a lot of myoclonic seizures. One study on 2 epileptic spasms where photoreactive seizures are reported, so responsive to light. Another study on epileptic spasms where we talk about late response, and 2 cases of tonic spasms at the moment of waking up or during sleep. And also in this case we talk about the brain malformations that are not really linked to epilepsy with a negative MRI. The study also that Rocca was talking about was non-epileptic paroxysms, which is difficult to separate from real epilepsy. There are some characteristic kinds of seizures and other kinds of seizures, so it is very difficult to detect a real epileptic seizure. As you can see, so literature is quite limited, and in most cases seizures have different forms in the same patient. The most frequent ones are myoclonic seizures, jerks. But on minor studies we did not have enough data, so I could not put it into the graph. But in general, myoclonic crises are the most frequent ones. The relation with brain malformation is not sure, but we do not have enough data. So we had the need to study epilepsy in patients that we were following, that we knew through the association with this retrospective and prospective study. The objectives were study the electroclinic phenotype of epilepsy, so the clinic study part and EEG, and then the most efficient drug therapies, look for structural anomalies typical of patients with epilepsy and the possible relation or absence of relation with the genotype and the development and the onset of epilepsy. The final aim of this study is finding an efficient therapy for epilepsy, not just to eliminate the seizures, but to improve the quality of life of the patients, and not just that, the quality also of sleep, because we will see sleep is frequently disturbed by this kind of jerks, and if a patient can sleep well, it can be more attentive and more awake during the day. When I did my study, I had 33 patients. One had been excluded for a particular reason, so 32 patients, 16 with epilepsy. 5 patients were present in the prospective study at the time. Now there are new patients because there were new cases that were added to the association in Bologna, and because we had new diagnosis of epilepsy. But I am talking now about the retrospective study. This retrospective study started 2 years ago in Cervia with the first questionnaires that you filled in, and then it continued. It was carried on with interviews to parents. Maybe someone of you will remember this. Interviews about the age of onset of the epilepsy, on the description of the seizures, the factors, triggering factors, and the response to therapy, the side effects of therapy, the evolution during time, and sleep disorders, sleep problems due to these jerks. Then I asked you to send me the EEG and the images. Of course, the limits are those of a retrospective study, so anamnesis has been collected in this way. We have not followed patients in time, but we have reconstructed their history according to the description of parents. So it's something very personal, and it's not made by specialists. EEG had been made in different centers, not always in the same way, not always with response to the light, often without video, and often we did not receive the image, but only the results. And so not always the results that we have are really clear, but in this case, one person has assessed this data in blind, in a homogeneous way, with the same questions for everybody. So what came out? As you can see, the most frequent seizures are the myoclonic focal crisis and tonico-clonic crisis. In the retrospective study, the patients were often older. This explains the clonic-tonical crisis. And then we have other cases of seizures. There are patients who have more different kinds of seizures during their life. The average age of onset is 3 years, 9 months, but myoclonic seizures tend to appear between 0 and 18 months. So when the baby is really young. And then there is another age, the scholar age, when it is more frequent to have the onset of tonical seizures. The time of the day also is important in our opinion, because everyone said that seizures were present either when falling asleep, or during the sleep, or when waking up. In general, let's say in transitional phases. So this means that the patient cannot sleep well, and so it is asleep during the day and finds it difficult to pay attention during the day. There are some triggering factors. You have frequently talked about seizures triggered by the light of the house when you switch on or switch off the light, or triggered maybe by sounds, noises, very strong noises, or seizures that are more frequent when passing from one season to the other, or in periods of particular stress for the person. In particular, the element about light is important for us. We could think that there is a sort of reaction to light, and this means that epilepsy in PKS patients has to be studied with EEG that studies light, the intermittent light. And this becomes important because we can avoid to use or to do some actions that can be a triggering factor for the patient. There are different kinds of therapies. Only in 3 patients had only one kind of therapy, the monotherapy. All the others were following a polytherapy. Most of the patients modified the therapy at least once in their life, and 5 patients at least 2 times in their life. 2 families talked about an excellent response, so a disappearance of these seizures. We noted that in patients with levetiracetam, the response was good. The EEG that you showed us, that you sent us, showed that during the sleep and during paroxystic anomalies, there were some anomalies that were localized in temporal regions. Then the last question that we had put in our questionnaire, brain malformation. Does epilepsy come from structural anomalies which are characteristic of this syndrome? Because 50% of the patients suffered from epilepsy and 50% didn't. Why? Does it depend on structural anomalies? In our case, the exams were absolutely normal. Or in other cases, there were the mild anomalies, so it doesn't look like related to structural anomalies. And in the group of people without epilepsy, there can be structural anomalies, and they are frequently present, but they do not have epilepsy. So the conclusion is that we need more neuroimages. We need to compare them, the ones of patients with epilepsy and without epilepsy, to check if it depends from structural anomalies, or if we have to focus on the 12P region and see if it can come from genetic causes, from genetic differences from the 2 groups of patients. And now I give the floor to Professor Ricci to talk about the prospective study and EEG images.
I will try to be brief. The state of the art has been already and widely analyzed together with Valeria, and I would like to show you this slide just in case you want to see something more or again later on. As she mentioned, and sorry because we have disturbed you with several phone calls. As you know, with the her thesis, we started analyzing seizure and ECG graph, and we understood that these elements were correlated with other aspects that had to be studied, such as sleep disorders, stereotypes, and cognitive and behavioral disorder, and neuroimaging. And my colleague will give you further information about that, but what we have done was to create a protocol of study approved by the ethical committee of our hospital immediately after our meeting in Cervia. So we had standardized data providing element that could be compared, because usually in research work, especially in this kind of research works, it is difficult to find out the right method, and the method is essential and must be thoroughly device. So we defined the electroclinical phenotype and its evolution with the view to find the most effective therapies to evaluate the correlation with cerebral malformations, as Valeria mentioned, and the association genotype-phenotype. So this was at the beginning a monocentric study, but now it is transforming into something different with retrospective and prospective features as well. I don't want to mention this slide because you have already had the opportunity to have information, but I would like to underline the fact that from 5-10 patients at the beginning of the study, now we are able to observe the 14 patients, also thanks to your collaboration. What we do is collecting data regarding all the patients so that they can be compared. And now I'm going to show you the preliminary result on a population of 14 patients with an age range ranging from 5 patients with less than 1 year, patient with 1 year and 3 years, patient with between 1 year and 6 years, and patient older than 10 years, and of which 8 suffers from epilepsy. And another point that is not present in this slide, 9 patients were able to carry out video ECG monitoring day and night, and this was very useful to provide data. The date of onset is a median of 3 months and 3 months and 6 months. And as we had already understood in the retrospective studies, some of them has a very early onset, and 3 out of 8 between 7 years and 9 years. So we were able to identify the onset of the epilepsy in 2 moments, and we are talking about 2 different kinds of epilepsy. 5 patients out of 8 have myoclonic seizures, and all patients with myoclonic seizures have reflected myoclonic seizure. All of them are photosensitive. Some of them are triggered or happen during feeding phase in presence of noises, but we were not able to record them. 2 out of 8 have epileptic jerks, 3 out of 8 focal crisis, focal seizure, and the moment, as Valeria said, during schooling age, crises and seizures are mainly focused during sleep. Data are still very few, but 5 patients needed to modify the therapy at least once, so it was not an immediate management of epilepsy. Few patients more than twice. In 4 patients, we were able to fully control seizure, and 2 are under treatment with levetiracetam, and few of them with valproic acid. I have briefly outlined the features with this graph in the sorry, I'm not able to use the cursor, but in the small patient, the first little square is referred to myoclonic seizure, and in preschool in age focal seizures. Those represented by the darker area are data of the retrospective studies, so substantially data were mutually confirmed, and photosensitivity is common in all children with myoclonic epilepsy. This slide can be useful because sometimes you are I can understand that you are curious. I can appreciate that you are curious because some of the elements are not immediately understandable. Apart from the Caesar, we could also identify peculiar features of the graph, occipital features, more enhanced during sleeping, rapid activity, especially during sleep, while in older children, long sequencing of theta-delta activities, which are the two lowest activities. As you can see, they are wider curves, wider waves, compared to standard parameters. So they have long sequence of this activity. As you can see, the shape of the curve is very homogeneous and it is lower compared to the reference parameter. The older children have less, the graphic is less present. And here on the left, you can see the frequency, standard frequency. And on the right hand side, on the occipital areas, you can read O, is what we see, the same frequency in children with PKS. As you can see, we can observe lower and slower waves. This is the observation during sleep. And these are the moments of activity we could observe in older children. I know that you have already seen these slides in previous conferences, but there are new faces, and in any case it is really interesting to see myoclonic seizure in presence of light, and due to luminous stimulus you can see the jerks. You can easily see the jerks. Initially we have seen 2 children. Today we have 5 children because this datum was confirmed during the last year, and the last child on the right has jerks while feeded. He's drinking and he has a jerk. I hope you were able to see it. This is after the beginning of the treatment. The clinical phenomenon is slightly milder. You can see movement of the eyes, and then clinically interrupted with almost the complete interruption with clinical consequences, because most of the time after this jerk children cries and are quite distressed. In this image you can see a very quick movement of palpebrae due to the change in natural light, not only due to artificial light and due to the EEG flash, but also due to natural light. I'm not going to show you all these features, but this is the new chapter, older children during sleep, recorded during sleep. And as you can see, they also have movements and jerks. Some of them we are still in doubt. We don't know if they are just sleep disorder or seizure. Difficult to say. We need some more time to observe it and to compare different graphs. I'm going quickly because you have seen some of these slides. These are episodes mainly related to motor skills. I need, as you know, to be brief, but this is another child. It takes some time, but you should be able to see it. I could have eliminated part of the slide, but yes, now you can see the movement and the graph. More often this kind of seizure leads to the interruption of sleep, so they are really disturbing. And in this slide you can see 3 sequence of videos, different positions, as you can see, just to show you that according to our observation they are clinically quite similar. This is an EEG seizures, and to conclude with 2 peaks of onset age with the homogeneous seizure patterns. The question we asked was if this was due to the implication of different genes, but of course we are talking about very basic consideration. Another doubt we had was concerning the identification of the episode during sleep and to understand if we are observing real epileptic seizure or not in order to define the correct treatment. But the most important thing is to find pharmacological therapy, the most effective one, of course, but to do that we need to go farther on with the studies. And I think it is useful to reward you for your trust. I would like to show you this slide, which is the publication, our publication containing these first considerations, with a very brief summary of what we have done to disseminate information. We have also brought a oral communication poster with ALISE, which is the Italian Association for Epilepsy, and the same with the Italian Association of Pediatricians. And next week we will participate to the European Congress of Pediatric Neurology. So we are making a great effort to disseminate information as much as possible in order to find out the best possible treatment for children everywhere. Thank you. Thank you for your attention. I'm sorry to have forced you to reduce and to shorten your presentation. Thank you for being so quick, but this is a very important issue for us as families, and it is a huge effort you are making, so thank you for that. Emilia, with Professor Cordelli, you made an extraordinary work, so we would like to thank you. And in any case, I would like you to give the opportunity to ask questions. Dr. Bonfatti will give his speech in the afternoon, maybe slightly earlier, after 4 in any case. Any question? I would like to know if you can quickly explain the differences between epileptic tonic, focal, myoclonic and neuroclonic seizures. Very quickly, neuroclonic seizures have muscular contraction, very rapid and very quick, while tonic seizures, muscular contraction is much more long, and there is so the muscle is rigid for longer periods. Can they be triggered, or can they start as focus and then transform into myoclonic? Because in my opinion, Federico, my son, is like that. I should have a video. You mean a first phase focal and then myoclonic? Yes, definitely true. It is possible. Yes, correct. Tonic-clonic seizures. The one on the left was Sarah, my daughter. I would like to know. Usually it's the mother, very much involved, but and considering that she's already under treatment, with Tegretol. She still has these seizures in any case, especially after 1 hour of sleep. Yes, I was asking the same question yesterday to Professor Cordelli, because not always we are our information updated in real time. Yes, we could consider to modify the therapy in this case. We have something in mind. There are a few possibilities to modify the treatment. She started with Capra, but Capra increased the seizure to 4 per day, while with Tegretol we have an average of 1 seizure per night. And what about without any kind of treatment? She had seizure also during the day. They were not clear seizures, an extreme seizure, and not without and not of a long duration. They were just jerks repeated during the day, also when she was at school, and they were not triggered or associated to specific episodes. Some of them were just look like tonic spasms or jerks, but we didn't observe them directly. We can talk about it later. It is useful and interesting because semiology as myoclonic or tonic seizure can have a very clear description, but actually if we don't see them we cannot help you. So please use your mobile phone to record, and because the description is difficult for physician, can you imagine for non-physician? So thanks to the use of mobile phone, it has been extremely important to observe directly the seizures. Just one question concerning the last slide with the list of the there are some hidden information. Actually, we have some secrets. Now, I'm just curious to know if these are the genes. Yes, using literature on neuroimages, we had observed some of the genes positioning in that region, and we had tried to make some analogies and comparisons. So my question is, concerning the mechanism for every single gene, we know that sometimes they are more associated to loss of function or loss of efficiency, while for the other gene is slightly different, and I don't remember exactly which is the individual implication in epilepsy. But in general, without considering that there could be a general distinction that goes beyond these aspects, are there genes with the clear phenotypes? No. This is another input for you. So Dr. Pepucci is one of the most important experts of genetics of frontal nocturnal epilepsy. So we are trying to involve him as much as possible. Some of these genes are studies on, you use them just to identify which genes are involved in other epileptic syndrome regarding 12p chromosome. Some of them are correlated to malformation. Others are the result of different research. We have just made a research on PubMed looking for 12p genes correlated to epilepsy or epileptic syndrome with the gene coming from that region, but actually we don't know if we are still working in that region for what concerns PKS, so we have to go on this aspect. I would like to make a comment on the importance of these studies you are carrying out in Bologna, because for those working with children affected by rare disease, it is extremely difficult to understand, because most of the time it is a complex situation. There are difficulties in communication, intellectual disability. So it is really difficult to understand what's happening to them. It is difficult to say if they are critical or behavioral features, and so the only possible way is to record the seizure during the day, during the sleep, with lots of patience. And I know it takes time just to understand also the electric pattern that can be typical of the syndrome, not necessarily something pathological which requires treatments or therapies. So sometimes the opportunity to understand more and to understand more what's happening to them also from the electrical point of view give us the opportunity to treat them better using less drugs. So this is an essential study, and it was lacking in the past. I would like to add that we do believe in the fact that if we have an homogeneous recording and a good quality recording is an advantage. But the monocentric underlined by Emilia is a work we are carrying out also together with Maurizio, and we are trying to interpret these data, and we need to have a confrontation and to create a panel of experts to be able to analyze this data correctly and to extract important and essential information to give you the best answer and best possible information. Any other question? Just a consideration, why don't you become promoter of multi-centric studies? So children are spread in the Italian territory. You have the opportunity to use us and through us to contact your colleagues in the different Italian universities in order to create a greater and wider team. It is what we are trying to do. It is exactly what we are trying to do. It is a multicentric study, definitely a multicentric study. When it is possible, we concentrate or focus on some aspect in order to make recordings more homogeneous and more accurate, in order to be compared using the same method and processed using the same data. In this way, we can obtain sounder data. But even if we cannot reach 100%, 80% is fine as well. And we do hope to cooperate with many other colleagues. The same Dr. Giordano, the author of the first research study, probably the best study so far published. And it would be important to have him as well as many other colleagues involved in the group and joining the group. So yes, it is what we are trying to do. It is a very inclusive family from all aspects, from all points of view. And at levels of dates, we have asked the Genetic Commission for Epilepsy to be able to present this project to the next meeting. So thank you. Thank you so much, because we are proud to be able to support this study. And it's an honor for us to be part of this research. And I totally agree with you, Professor Vignoli. Thank you, Dr. Ricci. Thank you, Dr. Cagnazzi. And now I would like to pass the floor to Dr. Di Pisa for the study on the sleep pattern.
Good morning, everybody. And first of all, thank you for inviting me here to talk about our projects. I will talk about the study of sleep. We decided to focus on sleep. Emilia has already said a lot about this, but we wanted to focus on sleep in PKS because in literature there are no studies and no systematic studies in particular for sleep in PKS. There is an article of 2012 where all the developmental and behavioral characteristics are explained, and it also talks about sleep disorders. A questionnaire has been given, has been filled in, and 5 patients out of 15 had frequently woke up during the night and also had respiratory problems, in particular apnea, sleep apnea. These problems actually are very frequently reported by families, and they have a negative effect on the quality of life of the patients and of the families. So it's worth to go deep in this topic. There are several data in the literature concerning the prevalence of sleep disorders in children with other disabilities, and in particular in other genetic syndromes. One part of this study has already been carried out, and the objective of the first part was to analyze sleep disorders and assess their topology and their frequency, and assess the evolution in 3 stages of age. So pre-scholar age, scholar age, and older people. 25 patients were part of this study thanks to your collaboration, from 1.5 years to 23 years and 4 months. 7 out of these 24 patients are followed by our Sant Orsola hospital, while 18 patients have been contacted by telephone. We gave them a questionnaire which is one of the validated scale for the pediatric age. This scale is made of 26 questions. And these 26 questions managed to analyze 6 under typologies of sleep disorders to investigate these sleep disorders. In particular, when people have a few hours of sleeping, when they frequently wake up, when they find it difficult to fall asleep, if they have respiratory problems during the night, or if they have apnea, there are questions, for example, does the child wake up? What does the child do? Does he sit during the sleep? Does he scream without waking up during the night? Or disorders of the transition between the awake state and the sleeping state. Disorders when falling asleep, bruxism, and so on. And then if the child is sleepy during the day, drowsiness, and hyperhidrosis during sleep. So an excessive sweating during the night. These are the preliminary results. 21 patients out of 25 had a pathologic or borderline score on this scale. Then we analyzed the other scales, subscales. The prevalent result is the disorders, the problems during the transition between the awakeness and sleep. Then we find also respiratory problems and drowsiness during the day. On the contrary, we have a low hyperhidrosis. And we know that in this syndrome we do not have hyperhidrosis. Then we divide it according to the age, and we analyzed the pathologic scores per age. In the preschooler age, there is a transitional disorder with a pathological score in half of the patients. In this case, we have 10 patients in preschooler age. And as for the schooling age, 11 patients, the sleep disorder is much more frequent with respect to the two other groups. Drowsiness is the most present problem. As for the older people, so 4 patients, it's a very small sample. As a total score, no one of them had a pathological or borderline score. But in the different scales, there is the respiratory disorders. So this data for the moment confirm this presence of the respiratory disorder, as it happens in other syndromes that have already been studied, like Down, Prader-William, Angelman, Mowat-Wilson syndromes. And also in this case, we should try different drugs to improve the quality of sleep, from melatonin or other drugs like neoprosine, or other drugs that have an action on sleep, in order to improve the quality of life. And why not also improve the behavioral aspects and the cognitive aspects. This is a data that has come out from interviews. It was not a specific question in the questionnaire. What we discovered is that in 15 patients out of 25, there is the tendency to sleep not covered. We tried to understand if there was an underlying reason for this, and what we suggested, as you can also see in the article that that I have quoted before, we see that there is a sort of hypersensitivity of these people, so a sort of defensive attitude. So being covered during the night could be a sort of disturbance for them, something that they do not want to feel. There is also this tendency to have a reduced sweating, so maybe this is also why they have this characteristic. This is something typical of the syndrome. We cannot find it described for any other syndrome in literature. So with this first part of the study, we saw the presence of sleep disorders, or most of all in the first part of sleep and in the transition from being awake to being asleep. The possibility to implement therapeutic interventions can be done, but this study is limited to the answer that we had through a questionnaire. So we have to validate these results through a video polysonographic study during the night. This is our future project that we have already started. We have already found 9 patients that are available for this study. We hope to reach the number of 15 or 20 patients. Of course, this kind of exam, this kind of study needs to be hospitalized in our hospital in order to monitor them for at least 24 hours. The ideal would be having 2 nights. The first one to be adapted, because it's quite a demanding exam. There are a lot of wires. There are 19 EEG wires. We have to study the breathing. So there are a lot of breathing parameters to study. There are the muscles to be studied. So it is not easy. It's not easy. But this has the aim of assessing the quality of life through a parameter that is defined sleep efficiency, and try to identify patterns or evolution in the architecture of sleep, linked maybe also to the age. When we talk about the architecture of sleep, we mean the phases of sleep. So the stages, how long they sleep profoundly. There is a difference between deep sleep in children with PKS and children without PKS. And also we will assess the presence of sleeping disorders. So do they have apneas or not? Do they snore or not? Thank you for your attention. We are at your disposal if you have any questions. Thank you also to all those who already took part in this study.
Thank you, Dr. Di Pisa. We are perfectly on time, so we have 15 minutes to devote to questions. So please use it. Thank you. I would like to ask a question. Children with night snoring, do they also have evaluation of nasal and throat evaluation? In theory they should, but actually up to now it was not done, but our intention is to include it for the future. Is there also monitoring for apneas? Yes, we also consider saturation and cardiac frequency. We have to consider all these parameters. We haven't observed severe desaturation, but all these parameters have been evaluated, has to be evaluated. We had to hospitalize our daughter because she had hemorrhages, and the praxis is to put saturimeter, and it was ringing all the time during the night, and she had problem of saturation during the night, and they considered it of a quite severity, and so they had this kind of study, and they put her under a sort of monitoring of nocturnal saturation and also heart frequency. Regarding heart frequency, at the beginning it was 70 and it kept on ringing, and then they set it on 80, and then they set it at 50, but it kept on ringing also under 50, and desaturation going to the seaside improved hugely, and so we removed CPAP at the seaside because it stopped desaturating. It is normal because of a peripheral problem more than due to the central problems. No, the heart frequency should be analyzed, and probably the rhythm should be analyzed. Another things we observed is that she snores
especially in winter, when she has cold or she does not breathe perfectly. I understand, but if the situation is of this kind, probably we should have a different kind of analysis to solve this kind of problem. Sorry, when she was hospitalized, also the nose specialist was involved, and probably the adenoids had to be operated, but our daughter has runs risk due to anesthesia, and they couldn't intervene. In my treatment experience, regardless the different specific diagnostics, the use of melatonin or neoprezin in the clinical practice seems to be considered, but seems to have different diagnostic effectiveness. Does it relate or is it related to the dosage? And second question, with the growth, if there is a sleep disorder which is prevalent when children are very young, does it improve or disappear after puberty? Yes, it is true that this problem improves with the age. As for the pharmacological aspect, in our experience, regardless from PKS or from other syndromes, for sure, melatonin with a higher dosage, respect to the standard dosage, is much more effective. And compared to neoprezin, definitely it is more effective. It is more effective than melatonin. It is slightly more difficult to have it. That's why most of the time melatonin is prescribed, because the other drugs is much more difficult to be found. All these speeches and all these results are strongly connected among them. The study of the sleep patterns and monitoring are useful to better understand epilepsy, better understand neurological problems, better understand sleeping disorder, but also better understanding, if I remember correctly, that with the study carried out on Sarah, there weren't these problems, but we were able to observe other aspects, peripheral aspects, but it is essential to integrate all this information, to create a collage of all this information. It is a very useful examination, even if it is demanding, definitely true. And you family, talking about that exam, I know you agree that it is quite demanding, but it is extremely useful not only for the research, but also to find out accurate information about the individual, the single child, or boys or girls. Any other question? Because now you are too clever, too smart. We have 8 more minutes. Sleep disorder correlated to epilepsy or to respiratory difficulties. It is definitely true, but I also think that cleft palate have an impact in this, and sometimes also adenoids can have an impact. So probably it is sleep disorder, it is epilepsy, but it is correlated with many other events. Yes, definitely true. In some cases, there can be apneas due to central origin, but most of the time are peripheral apneas due to the features you have just described. I would like to know if, beyond this investigation carried out on the child, the questionnaire contemplates also the impact that sleep disorders have on the family, because it is a situation which deeply involves parents. It is definitely true to find out the main reason of child's problem, but I'm sure that there must be literature data also regarding the response and reaction of parents to this distress, to this very critical condition. For PKS, we have no data available. For other conditions, for other syndromes, yes, we have data available and specific questionnaires administered to patients, not the questionnaire we have administered to PKS parents. Few more questions if you want. Sometimes, rarely actually, it happens that Angelica, while sleeping, screams or she seems to be scared, and we do connect it that maybe she had a nightmare or she's having a nightmare. Is it something that you have already observed or that you have included in the questionnaires? It is something which is commonly referred, and we can commonly read on questionnaires. Could this be triggered by a nightmare? Of course, we cannot be sure about that, but yes, it could be correlated to a possible nightmare. If there are no other questions, let's say that we can stop now. Just few information. On the table of the speakers during lunchtime that will take place in this same room, I will leave my planner to book the examination for Sunday morning, so please write your name in the proper pages. For nose here and through specialist at 10 o'clock in the morning in the registration room. For pediatrician and neurologists, they will be in the surgeries close to the sensory room just behind us, in the thermal center, in the spa center on the first floor, beginning at 10:30. 10 o'clock, odontoiatrist, and 10:30 pediatrician and neurologist, and then according to the planner we will arrange and we will create the schedule. We will try to understand which is the request. Second information, don't run away, because as soon as children arrive, we have the group photographs all together. So if you have to go to the sensory room to pick up your child, please go, and we meet outside on that way in front of the old spa center. If you don't know where is it, it's when you go out to go to a sensory room, you will find this building on your left. It is an ancient building, and there is written Salvarola Terme on the facade. Thank you so much. And thank you to our speakers. Thank you.